Hello, and welcome to today's webinar, What Clinical Trials Are Recruiting for Recurrent Ovarian Cancer? I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, and helplines, please visit our website at sharecancersupport.org. And today's program is extra special because it's SHARE's 10th annual Joan Summer educational program. Joan was a nurse diagnosed with stage 4 ovarian cancer at the birth of her third child. She lived with ovarian cancer for 22 years. With her natural wry humor and intelligence, Joan and her family inspire the SHARE community. The summer legacy continues with programs like this. We're very excited to have Dr. Cohen joining us as today's speaker. And now I'd like to hand it over to you, Dr. Cohen, to introduce yourself.
Thank you very much, Maggie. And it's so wonderful to spend the evening with you discussing clinical trial opportunities for recurrent ovarian cancer. I want to thank Share first for all that you do for our patients and their families. Really grateful for the efforts of the entire organization. I also want to say thank you to Miss Summer and her family for making this possible. Truly a wonderful opportunity for me to be here, and I'm so excited to get to talk to everyone about different research opportunities for patients who are impacted by ovarian cancer. I'm based in Irvine, California, at City of Hope Orange County. I'm the medical director for gynecologic cancer at City of Hope Orange County. We are in the process of building a brand new $1 billion hospital here in Orange County, designed specifically for cancer patients, and I'm so excited to be a part of that, and really excited about the research opportunities that we're going to discuss today. I spent many years at UCLA, and I grew up in Southern California, so it's great to be practicing in the place that I grew up and help hopefully improve the care for patients that are impacted by gynecologic cancer in Southern California. City of Hope has a national footprint, and I'll talk more about that at the end, because I think that is important when we talk about clinical trial opportunities, to know that there are networks out there that you can reach out to, and whether you live in Georgia or Illinois or Arizona, potentially, be able to meet with a specialist who can give you insight into those trials. So with that, we'll move to the next slide, please. And what we're going to talk about today is going to be a summary of available clinical trials. It's really impossible in about 40 minutes to go into every in-depth trial available across the country. So I've picked a certain group of trials to be representative of what is available for you, with the goal that if there is something that you think you may be interested in, or you have a family member who may be interested in, if you're watching for them, that you then can target that. And I'm going to give you some resources on where to go to find those trials. Again, whether you live in upstate New York or Idaho or New Mexico or California, because I think those tools are going to be the most important part of tonight's talk, not necessarily the exact trial itself. But I will go through specific trials, and I've written down, I was talking to Maggie earlier in Victoria, I've written down as many of the states as I can to give you a sense of where these trials may be open for you. But first and foremost, just wanted to discuss the things to think about when you're perhaps a patient or a family member with a patient dealing with recurrent ovarian cancer. You want to have your medical team, and when they talk to you about recurrent cancer, it's really important to understand how they've defined that. Do they believe you have recurrent cancer based on a blood test, a CA125, which is a protein in the blood? Do they believe it's based on imaging, a CT scan or a PET scan or an MRI? Do they believe you have recurrence based on a physical exam finding, perhaps a mass that they can feel in your abdomen? And then, do you need a biopsy? And that comes up as a question, and you may think it's obvious. Of course, we're going to get a biopsy, but your doctor may not think about that. Your doctor may say, hey, you have a history of ovarian cancer. I see a mass. I think this is recurrence. We're going to treat you as such. But there can be a role for getting a biopsy, depending on if there's a concern for a second cancer or even a new tumor analysis, which we'll talk about as well. You want to address, do you need more imaging? Have you just had a CT scan of your abdomen pelvis? Do we know what's happening in your chest? Maybe there's an equivocal finding. Maybe there's a lymph node that's 1 centimeter. It's a little bit bigger than it was before. Do you need a PET scan? Is that going to be additive to the way that you approach things? And these are questions I talk about with my patients all the time, whether we should do more imaging or not. So I would encourage you to interact and ask this of your providers. We know that patients do better when you have a multidisciplinary team working with you. And if you have ovarian cancer, you should have a gynecologic oncologist involved in your care. We know that most patients actually get their treatments through a medical oncologist. A medical oncologist is an internal medicine doctor who specializes in cancer care. They do a special training called a medical oncology or hematology oncology fellowship. They're board certified, they're excellent, and you certainly will benefit from their care. But we have very clear data that for ovarian cancer patients, they do better when they have a gynecologic oncologist working with them in partnership with medical oncology often. But you should be seeing someone like me who's able to give you guidance as a board certified gynecologic oncologist. You also want to ask, is your case being presented at a tumor board? Even if it's not a comprehensive cancer center, most hospitals or cancer centers now have a tumor board. It's basically a meeting where radiation oncologists, medical oncologists, gynecologic oncologists all get together and we talk about you. We talk about the imaging, we talk about your treatment history, we review the pathology, and you should really ask, is my case going to be presented? Do you feel my case should be presented? Because every now and then a new idea pops up because you have 12 to 20 cancer doctors all thinking about you. And we know that that can be beneficial for the patient. Seek an opinion if you can at a National Comprehensive Cancer Center. It's called NCCN. NCCN is basically a group of cancer centers that meet certain guidelines. They've been basically approved by the government because they have these metrics. Wherever you live, if you can get within driving distance to an NCCN cancer center, if your insurance allows, seek it out, get an opinion there because you will find that you'll have more resources and opportunities at that cancer center, more likely perhaps than maybe where you're being seen currently. And just know there's not always one answer to what to do next. This is an art. It is a chronic condition when cancer comes back. And we have to be cognizant of both your wishes, what's available. So there's going to be more than one option. And that's why getting another opinion is okay, because you may hear something different that could spark your interest and maybe you pursue a different path with treatment. Next slide, please. So when we talk about different types of DNA testing, it's really important to understand there's DNA that you inherit from your mom and your dad, and there's DNA inherent in the tumor itself. The DNA that you inherit from your mom and your dad is in every cell in your body. It's everywhere. It's your blueprint to your body. The DNA in the tumor is a spontaneous mutation that can happen, and that's most of the time how cancer forms, a spontaneous mishap of the blueprint as the cells are dividing. We as cancer doctors want to know both the blueprint of the DNA from your mom and your dad, as well as the blueprint from the tumor itself, because it has implications for what drugs you may respond to. So when you're meeting with your cancer team, ask, hey, have I had DNA testing of the germline, which is the DNA from my family? And have I had the recent testing of the tumor, which is the somatic testing? Because again, it has implications for what drugs you may respond to. Next slide, please. Things that you should also ask, where is the tumor located? Is it in one spot? Is it in many spots? Is it in my lung? Is it in my abdomen? Is it in my pelvis? What type of tumor are we dealing with? Ovarian cancer is a group of diseases in many ways. It's not just one tumor type. And that has implications for the clinical trials that you may qualify for in the setting of recurrent ovarian cancer. And I'll show this slide in a little bit that shows the different types. Again, the genetic testing. Did I get testing of my DNA from my mom and my dad? That's a blood test and saliva test, one or the other. Have you sent my tumor for testing? Do we have an updated molecular signature to know if my tumor will respond to other drugs? Dr. Cohen, what about surgery? Is this lesion, if it's just one location, take me to the OR. Let's cut it out. Let's do something different. And we do that. We do that at City of Hope. We do that. Other cancer centers do that. And there can be a role for surgery, but it has to be in the right setting. It's not for everybody. Has the tumor been tested for something called folate receptor alpha? This is a new target as far as treatment. It's been FDA approved now for a drug called mirvetuximab sorbentansine in the setting of recurrent ovarian cancer. Your tumor should be tested for folate receptor alpha if you have recurrent epithelial ovarian cancer. Has your tumor been tested for HER2, HER2? This is a target that was often used in breast cancer, and we now use it in ovarian cancer as well. And if your tumor is positive for HER2, you probably have some good options with drugs that target that receptor. Has your tumor been tested for estrogen receptor progesterone status? Is your tumor sensitive to hormones, ER and PR, estrogen receptor, progesterone receptor? The response rates may not be as good as standard chemotherapy, but for patients in the right setting, hormonal therapy, just like in breast cancer, can have an option. And then the most important question, which is what we're talking about today, is Dr. Cohen, do you have a clinical trial that I will qualify for? And if so, what are the benefits and disadvantages of that trial? Next slide, please. Different types of ovarian cancer require different trials, and they require different expertise sometimes. They're just like colors of the rainbow or colors of crayons. There are different types of ovarian cancer. There's low-grade serous ovarian cancer, clear cell tumors, carcinosarcomas or endometrioid stromal sarcomas, granulosa cell tumors of the ovary. The one that I want to make caution of is if someone tells you that you have mucinous ovarian cancer, that's a diagnosis of exclusion. Usually, mucinous tumors start in the GI tract and they spread to the ovary. And so your doctor needs to have done a formal workup, including likely removing the appendix and doing an EGD and colonoscopy. An EGD is a camera looking at the stomach and the upper intestine to make sure this is not a cancer coming from the intestine, because that has different treatment options instead of a primary mucinous tumor of the ovary, meaning instead of a tumor that truly arose from the ovary. And then endometrioid tumors of the ovary. See, these are all different types. I'm sure the people who are listening, our wonderful patients, are thinking, what type is mine? Or you know exactly what type yours is. But you should know that because it has implications for your clinical trial enrollment possibilities. Next slide, please. Other things that are important to know when you're talking about recurrent ovarian cancer are your prior treatments. When we as physicians are making decisions with you about the next treatment, one of the most important things is, well, what treatment have you been on and when was the last time that you received it? And that has implications for both clinical trials and other drugs that you may qualify for. The other thing is, again, the subtype of ovarian cancer. Is my tumor high grade? Is it low grade? Meaning, does it look like it's dividing slowly or quickly under the microscope? Is this a serous tumor? The most common form of epithelial ovarian cancer is high grade serous. Is it an endometrioid tumor? Is it a clear cell tumor? And then is the tumor considered platinum resistant or refractory? Carboplatin and cisplatin are the two most common chemotherapy drugs we use for ovarian cancer, and we use it in the recurrent setting as well. But if the tumor grows within 6 months of receiving these drugs, we're less likely to use that same chemotherapy because we think it may not be as effective moving forward. If the tumor grows while you're receiving carboplatin or cisplatin, we call it refractory, meaning that we really don't think it's going to respond to that drug moving forward. And you want to know this yourself because it has implications for what drugs you can qualify for trials, and also what we can use in the future to treat you outside of a clinical trial. Have you received a drug called bevacizumab? I'm guessing most people on this webinar tonight or who are going to watch this separately have received bevacizumab if they started with stage 3 or stage 4 ovarian cancer. That has implications because some trials will not let you enroll unless you've already been on bevacizumab. Have you received a PARP inhibitor? PARP inhibitors are oral pills, and we used to give these in the recurrent setting, and we've moved it up to the initial setting. Many trials will not allow you to enroll if you're BRCA positive in the tumor or the DNA, or the tumor or the DNA of your parents, unless you've received a PARP inhibitor already. And you should have received a PARP inhibitor, or you should, if you haven't, if you qualify for them based on your genetic makeup. And then there are other conditions which make it hard to qualify for trials based on the type of drugs. So people who are dealing with kidney failure, liver failure, if they have a second cancer that we're treating actively, it can be hard to enroll in trials because they try to limit out, unfortunately, to know if the drug is working based on your medical history. If you have a second cancer, it may be hard to know what's working and what's not working if the two cancers are growing at the same time. If you have autoimmune disease, sometimes immunotherapy drugs can be dangerous for you, so we have to be careful with that. Also, how many prior lines of treatment have you received? Trials tend to limit out patients who have had multiple prior lines of treatment, meaning they have multiple treatments already, because the trial pharma companies that are sponsoring this know that drugs are harder to show benefit if you've already received a lot of treatment. When I talk to patients about ovarian cancer, I describe it as a chronic condition. Here in California, Magic Johnson is a well-known Laker, and he was diagnosed with HIV in the early 90s. We didn't think Magic Johnson was going to live a long time, but he's living a long, happy, healthy life because we've made HIV chronic with antiretroviral drugs. And that's how I view ovarian cancer now. For the patients where it does recur, which is sadly most, we're not looking at cure, but we're looking at remission, or we're looking at keeping the cancer at a low volume. And that's really the goal. Can we make this chronic and keep you on a drug and adjust with new drugs if we need to? We can, but the number of prior lines impacts clinical trial enrollment. So sometimes it actually makes sense to enroll in a trial earlier if there's an exciting drug we think you're going to respond to, and then use the standard drugs later on if we need them. And then other things are significant neuropathy, or vision changes may impact your trial enrollment, and then how independent you are. If you're not able to eat or drink on your own, if you're not able to walk on your own, if you're not able to use the bathroom normally, you may not be able to enroll in a trial because these drugs can make you very sick. Next slide, please. I mentioned the different types of ovarian cancer, and it is a misnomer to call this one cancer. It's also a misnomer to call this just ovarian cancer. We actually know that most ovarian cancers, especially the serous subtype, actually come from the fallopian tube, the distal end of the fallopian tube. So for what we were calling ovarian cancer for years is actually probably fallopian tube cancer. That being said, the three main categories of ovarian cancer are epithelial, germ cell, and sex cord stromal. And on the slide, you can see the differences. The most common type is epithelial ovarian cancer, but just know there are trials out there for all patients with these different subtypes. It's a matter of finding the right cancer center that has these trials for you. That's why it's important to talk to your medical team about the specific cancer type you have and whether you've had molecular testing. And again, is this an ovarian cancer? Did we think it came from the fallopian tube or the peritoneal cavity? We do treat them similarly, but sometimes it has implications for the tumor treatment approach and the tumor testing based on where it originated. Next slide, please. There are different types of clinical trials, and I know for this group who's logging in, I'm guessing many of you have already become familiar with some of these terms. But phase one is an early trial. It means that the drug is really new. We're excited about the drug, but we haven't really shown how safe it is. And the benefit of these trials is that you get exposed to the latest and greatest drugs, maybe potentially lifesavers, but it's a little bit more high risk, high reward because we don't know if these drugs are going to work. We also don't know all the side effects. But you can get exposure to some really unique, exciting drugs depending on your how well you feel and what you're willing to undergo. Phase two trials are drugs that have been tested already. There's some data on them, and we're really trying to see exactly how well they work. What's the response rates? And these are the more common trials where you're going to see it at cancer centers that are not comprehensive cancer centers. Phase three are the bigger trials. These are the trials that you're going to probably be able to do closer to home in the community setting. These are trials that are more vetted. They've already been through the initial testing, and now we're trying to see again how safe it is in the general population and comparing it to the standard treatment arm, meaning that the standard chemotherapy we would use otherwise, it involves randomization, where you may be randomized to the standard of care drug like carboplatin and Taxol, or a new investigative drug, which is the study drug. And the last phase is phase four. These are the final phase. This is where the drug's pretty much already FDA approved. It's shown to have benefit, but now they're doing the trial to see how much risk there is for the larger population when we look at patients of different backgrounds. Is there any safety signal that we missed? And those are called phase four. Next slide, please. So why do a trial? Dr. Cohen, why would I experiment? Why would I put something in my body that hasn't been proved thousands of times over? Why would I take that risk? Why would I want to do that as a cancer patient? I'm already dealing with the challenges of the cancer itself. Well, this is why you may gain access to a new life-saving drug that you would not otherwise get because the insurance companies are not going to pay for a drug that's not FDA approved. It's even hard to get them to pay for drugs that are FDA approved. You'll be answering important questions for other women who are dealing with this cancer in the future. You're going to get extra attention when you're on a trial. You're watched like a hawk. You've got a clinical trials nurse, maybe two. You've got a research coordinator. It's a little bit more involved because you have to answer questions about how you feel. You do have to come in more for blood draws, but they're not going to miss something in that trial because the whole point of the trial is to monitor you very closely for all these different things. So if you're someone who likes the idea of a little bit closer follow-up with the team, a trial is a good way to do that. And then you may gain important information about your tumor. I mentioned the tumor testing. Sometimes we do different testing that's not approved by the insurance if you enroll in a trial. And we may figure out that your tumor responds to certain drugs we may not have otherwise known simply because of the testing needed to enroll on the trial itself. Next slide, please. So remember I mentioned the tools that I want you to take away from this as far as finding the right trial. This slide is the tools. Share is an amazing organization. So go to sharecancersupport.org, seek out Maggie and Victoria and the team. They will help guide you if you need as far as maybe trial opportunities or at least get you to the right cancer center that can. Clinicaltrials.gov is the most important website I'm going to say tonight as far as finding a trial. Clinicaltrials.gov. It's a publicly available website. Every trial in the US has to enroll on this website. You go to the website, you type in ovarian cancer, you type in trials, and then maybe your state that you live in, and it will generate a list of those trials. And so that's where you can start. So clinicaltrials.gov. check it out tonight if you're interested in a trial. And we'll tell you, if you live in Florida, what trials are in Florida for ovarian cancer. If you live in Idaho, what trials are there for ovarian cancer. Clinicaltrials.gov. Other websites that are really helpful, other great organizations, and Share is amazing. We're also fortunate that we have a lot of other partner organizations, the Foundation for Women's Cancer, the Sandy Rollman Ovarian Cancer Foundation, Clarity Foundation, Share It, the NCCN I mentioned, the Society of Gynecologic Oncology, which I'm a part of, and you can see the list here. So a wonderful list. Take this for what it's worth. These are great organizations. Start with Share and then clinicaltrials.gov and go from there. Next slide, please. There are different types of treatment for ovarian cancer. And ovarian cancer, I have patients who come in and say, Dr. Cohen, I don't want that poison in my body. I only want to go with natural supplements. That's my preference, and I'm okay with that. And I want you to know that as a doctor, while I have to follow the clinical evidence, I have to hold myself to a higher standard with what's available to recommend to you based on standard clinical trials. I also know that patients there's other things out there, and that's okay. We want to partner with you, but just know, for an example, Taxol, which is a chemotherapy, it comes from a tree. That's Taxol, what they're collecting on that screen. Okay, so Taxol is actually maybe the most basic natural product that we have, but it's a chemotherapy that we've made from trees. That being said, there's chemotherapy, there's targeted agents, there's hormonal therapies, there's immunotherapies, there's surgery. I'm fortunate that I get to do surgeries and do systemic treatments with clinical trials. Gynecologic oncologists are very unique. We're one of the few cancer fields where you get to do both, which is amazing. And that's what many of us do. Some of us only do surgery, some of us only do systemic treatments. I'm fortunate that I get to do both for my patients. There's radiation, there's integrative medicine. We're fortunate at City of Hope. We have an integrative medicine program run by one of our wonderful medical oncologists, Dr. Richard Lee. So I love when patients get to meet with him and talk to him about integrative medicine because they can work together. They're not mutually exclusive. Next slide, please. This is a summary slide. I'm not going to go through all these drugs, but this is basically our armamentarium that's FDA approved or approved by the insurance for platinum sensitive disease, meaning that the cancer should respond to carboplatin or Taxol. I'm sorry, carboplatin and cisplatin, because it's been more than 6 months since you received that chemotherapy. And if the cancer returns more than 6 months later, we want to include platinum in your treatment arm. And the exciting thing is this is growing by the month. And so nccn.org provides this list for patients and for providers. And so this is a really good place to go look if you're looking for the names of drugs. Next slide, please. Platinum-resistant disease. Platinum-resistant disease is basically disease that's recurred within 6 months of the last platinum. And it's a disease process that's a little bit tougher to treat because the platinum is our go-to initially. But you can see the list is growing, and that's why this slide is up. It's to show you that we do have options. Even if you don't do a clinical trial, there are new options out there. And this list is growing by a third within the last year or two. So we're really excited about how quickly these options are changing. Next slide, please. I mentioned PARP inhibitors. PARP inhibitors, every person with ovarian cancer epithelial should ask their doctor, Dr. Cohen and team, should I have been on a PARP inhibitor? Dr. Cohen and team, why did I not get a PARP inhibitor? PARP inhibitors are oral pills. About 50% of patients will benefit from a PARP inhibitor. And we know that the data says that you need to do the right genetic testing to figure that out. The FDA has come back in recent years based on safety profiles and said that you really shouldn't use PARP inhibitors in the setting of recurrent ovarian cancer. And the data does support that it's better used in the upfront setting in your initial treatment course. But if you're someone who did not receive a PARP inhibitor when you were treated at your initial diagnosis after chemotherapy, you still may benefit from a PARP inhibitor. And that's why this slide is here. Talk to your doctor about this. If you've never received a PARP inhibitor, there could potentially still be a role for it. But it's becoming harder to justify that because there are safety signals now that say in the setting of recurrent cancer, PARP inhibitors may not be the best choice. Really, if you have a BRCA mutation in your genes, your mom and dad genes or your tumor genes, and you've truly never received a PARP inhibitor, there probably still is going to be a role for it for you in the recurrent setting. Outside of that patient population, it really probably should be used only in the upfront setting. Next slide, please. And PARP inhibitors function. They basically are drugs that stop cancer cells from saving themselves. They are often used in combination with a drug called bevacizumab. Bevacizumab blocks new blood vessel growth. PARP inhibitors are, again, really good drugs. They should be used in the upfront setting, and if they're used in the recurrent setting, they have a role, but they have side effects as well. The most common ones are fatigue, nausea, and constipation. and that usually gets better. In addition to some bone marrow changes, it usually gets better after the first 2 or 3 months. But you got to get through the first 2 or 3 months to really get there as far as the side effects improving. Next slide, please. Antibody drug conjugates represent the latest and greatest. They represent really a newfound treatment paradigm for our patients with recurrent ovarian cancer. And the way I describe them is essentially Trojan horses or smart bombs. They're chemotherapy, which is a warhead, and I don't really like that term, but that's it's linked as a warhead, so to speak, to a linker that degrades and a receptor that binds to certain cells in your body. So the antibody receptor has the linker and the warhead. And this is a better way to give chemotherapy because, again, as a Trojan horse, as a smart bomb, it tries to find the exact cells it wants to attack. Chemotherapy, when given in the IV form or even the oral form, attacks many cancer cells that don't express receptors consistent with cancer. This is trying to overcome that and be more targeted. Next slide, please. Antibody drug conjugates, one of the real success stories in the last year or two has been HER2 targeting antibodies. So HER2, again, I mentioned, is a receptor. It's found in breast cancer, but we do know it's also expressed in ovarian cancer. And we now have some really good drugs that target this. One of them is called trastuzumab deruxtecan. If you have recurrent ovarian cancer and you're on listening to this, ask your doctor if you've been tested for HER2, both on the slides, how they look under the microscope, and in the DNA of the cell. Because if you express HER2 at a high rate, you should be on this drug, her trastuzumab deruxtecan, because the response rates are really very, very good. Next slide, please. Another target is folate receptor 1, FOLR1. And we now have a phase 3 trial that was published. Dr. Katie Moore was the lead author. The study is called Mirasol, and it showed a survival benefit. The first time we've seen a survival benefit with one drug in the setting of recurrent ovarian cancer, platinum resistant, in a decade. And that's a game changer. If you express folate receptor in your tumor, this is a drug that's now FDA approved, mirvetuximab soravtansine. You don't need to be on a clinical trial for this. You can receive this now. So please talk to your doctors about this. If you have recurrent epithelial ovarian cancer, ask your doctor what your folate receptor alpha expression is. And if it's more than 75%, you can get the FDA approved drug Elahere on its own. That's called mirvetuximab soravtansine, trade name Elahere. Next slide, please. So again, the first ADC or novel treatment to show survival benefit for platinum-resistant ovarian cancer, and it's the new standard of care for patients who have folate receptor alpha positive platinum-resistant disease. Next slide, please. Now we're going to transition to trials that are currently open or accruing. Again, this is not, there's just no way to do an exhaustive list here for you that without talking really, really fast or perhaps going over time. So I've tried to pick some trials that highlight the new exciting pathways for ovarian platinum resistant or platinum sensitive ovarian cancer, and maybe where you can see these trials. So Gloriosa is a phase 3 study. So this is one that has more data to it. It's a larger study now. It's in the setting of platinum sensitive recurrence, and that's what the red line is. I've tried to say. So again, patients that are responding to platinum, where your last chemotherapy was more than 6 months ago, if you test positive for folate receptor alpha, currently you could only receive it if your tumor was platinum resistant. But this trial is looking at whether women who are platinum sensitive would also benefit from this drug. So basically, if you enroll, you finish your standard of care drug treatment, which is what I would do with you or another provider, and then you would get randomized to receiving the drug mirvetuximab soravtansine with or without bevacizumab. And so this trial is going to answer the question: do women who have a folate receptor alpha positive tumor will they get more benefit by moving this drug into the second recurrence versus waiting for this to recur after the tumor is already platinum resistant, or the first recurrence? I'm sorry. Next slide, please. And that trial is open in many locations. So I think if you're in New York, Florida, California, Illinois, really any major comprehensive cancer center that's NCCN designated, that trial may be open. So if you go to the clinicaltrials.gov and type in Gloriosa under search, it's going to pop up and tell you whether that trial is in your state and if it's within driving distance. Another trial, which I'm really excited about, is something called a phase 1B trial. 1B is an earlier study. Ceralasertib is an ATR inhibitor. An ATR inhibitor is a drug that targets the ATR kinase in cells, and it's now being given in this study in combination with a new PARP inhibitor. So a PARP inhibitor that's not publicly available on the market. It's designed really for patients who may be platinum sensitive. Unfortunately, if there's a mucinous component to the tumor, or it's a low-grade histology, or a sarcomatous component, the trial would exclude the patients. It's really designed for patients who are going to be likely beneficially receiving a PARP inhibitor. So those who are HRD positive, homologous recombination deficient positive, or have a RAD51C or D mutation, or PALB mutation, or BRCA mutation. And again, it allows for patients who are high-grade serous or endometrioid histology, but not mucinous or sarcomatous. It's open in California. It's open in Boston. It's open in Charlotte. It's open in Philadelphia. And so really, again, clinicaltrials.gov will tell you exactly where it is. And again, one of the things I love about City of Hope is I'm fortunate that we have a lot of trials. And so oftentimes it's the rare patient that we won't have a trial that you would qualify for. Next slide, please. So GOG stands for the Gynecologic Oncology Group. The Gynecologic Oncology Group is a larger organization that I'm a part of. That we all it's a cooperative group, meaning that doctors like me work with the trials through the Gynecologic Oncology Working Group. This is a phase 3 trial. This is for platinum-resistant patients. This is a very exciting trial in that it has a virus in it. So there are some trials that have genetically engineered viruses that we use as doctors to see if we can improve response rates to standard chemotherapy. This trial is a good trial in that it has no maximum limit. So whether you've had 5 lines of chemotherapy or 2 lines of chemotherapy or 10 lines of chemotherapy, you can enroll in this trial. And that's really important because some patients who've had a lot of prior trials, lines of treatment, are limited by what's available. But again, if you're a patient who has ovarian cancer, epithelial, and you've had a certain number of trial lines of treatment, whether it's 2 or 6 or 10, it does not matter, you can enroll in this study. But you have to have had at least 3 prior lines. And it's very lenient as far as the different histologic subtypes: high-grade serous, carcinosarcoma, clear cell. These are subtypes that you can enroll on this study. It does not allow for mucinous, low-grade, or small cell. You must have received bevacizumab previously. It must be platinum-resistant or refractory disease. And it's an infusion. So a doctor like me would put a port laparoscopically into your abdominal cavity, and you get admitted to the hospital, and you get an infusion of this virus vector into the abdomen potentially. And then you get standard chemotherapy after, seeing if you get a better response rate with the standard chemotherapy. That's if you're randomized to the virus arm. The other option is that you may get randomized to the standard of care, which is a good option too. Meaning that if you were not going to enroll in the trial, you would still get the best available drug that's available for you outside of a trial, which is why I like this study, because you're going to get the standard of care, or you're going to get this exciting new virus that may or may not improve your response rates to chemotherapy. This trial is open in Alabama, Arizona, California, Florida, Maryland, Missouri, Michigan, Nevada, North Carolina, Ohio, Oklahoma, Tennessee, Washington, and I think a couple others. Next slide, please. This is an up and coming trial. So this trial is open in Japan and China right now, but it is coming to the US. So I bring it up because it's going to be hot off the presses for you soon. It's a phase 2/3 trial. It's open again through the Gynecologic Oncology Group. It's another antibody drug conjugate. It's targeting something called CDH6, and the name is a challenging name. It's raludotatug deruxtecan, and it's going to be for patients with high-grade serous or high-grade endometrioid carcinoma. It does require a pre-treatment biopsy, which means that radiology would have to do a biopsy with you, and you have to have received just 1 prior line of therapy. And you could have also received the drug mirvetuximab sorbentansine, which is the other ADC I mentioned earlier that's now FDA approved for folate receptor positive patients. It does exclude patients who have mucinous, low-grade serous, or borderline tumors. And so this is, again, an up-and-coming trial. It's not yet open, but it will be open here within the next 6 months to a year. And so I would encourage you to keep an eye out for this trial at clinicaltrials.gov. If you type in the Rejoice, REJOICE, or you type in CDH6 and ovarian cancer, it should pop up for you. Next slide, please. We have this trial open at City of Hope. We've enrolled a number of patients on this trial. This is the Fontana trial. It's a phase 1/2. So again, an earlier trial. It's a new folate receptor alpha target. So I mentioned mirvetuximab. Mirvetuximab is FDA approved. It's a really great drug. It's an amazing drug in that it's again showed an overall survival benefit, but it does have toxicity. There is neuropathy. It does cause some eye toxicity, so you need to be on eye drops and see an ophthalmologist. So we have new drugs coming out that target the folate receptor alpha that maybe have potentially less toxicity, or maybe they act a different way. And this is one of those drugs. It's a different drug. It's a different smart bomb targeting the same receptor. And so this is for platinum resistant patients. And it's really for patients who don't have to express the 75%. I mentioned the FDA approved the mirvetuximab ADC, but the tumor has to have 75% lighting up on the screen when you look under the microscope. This trial, you only need 25%, so that's a lower threshold. So more patients will qualify for this drug. And the nice thing about it is that it's something where you can have up to 3 prior lines of treatment, which is great. And it's something where it is open. It's open in California, here where we are in Southern California, Colorado, Kentucky, Texas, Ohio, Massachusetts, Oregon, Rhode Island. It's also opened up in Canada, in Quebec and Toronto and Edmonton for anyone who may be listening from Canada. And you'll find it at clinicaltrials.gov. But we're going to see a number of these folate receptor alpha targets. So this is one trial. Even if you don't live in a state that has this trial, you may qualify for another folate receptor alpha trial. So know what your expression is on your tumor, because that has implications for whether you would qualify for one of these trials that targets this new receptor, which is exciting. Next slide, please. Acrivon. Acrivon, if you go to clinicaltrials.gov and type in Acrivon, this is going to pop up for you. This is a drug that's called ACR368. ACR368. It's given by itself or in combination with a chemotherapy called gemcitabine. It's designed for platinum-resistant patients, meaning that the cancers come back within 6 months of receiving carboplatin or cisplatin. And the nice thing is that it allows for up to 6 prior lines of treatment. So I mentioned 3 prior lines, or the Olivex study allows for any number of lines, but this is a trial where you can have up to 6 prior lines, which can make a difference for patients again who have been treated already for a few years. And so this is a trial you would qualify for potentially. It allows for platinum resistant patients who have high grade epithelial primary peritoneal or fallopian tube cancer. And the nice thing it also allows for patients with a carcinosarcoma, which is a rare histology. And unfortunately, sometimes we have trouble getting patients with carcinosarcoma trials. This trial allows for that. So it's a trial that's open in Alabama, Alaska, Arizona, uh, Arkansas, California, Colorado, Connecticut, Georgia, Florida, Maryland, Massachusetts, Miami, Mississippi, New Jersey, New York, North Carolina, Ohio, Oklahoma, Oregon, Pennsylvania, Rhode Island, South Dakota, Texas, Washington, Wisconsin, Utah, um, Oregon. So number of places. I try, guys. I try to go through the list and generate where some of these places, where these trials are open. But clinicaltrials.gov. Okay, next slide, please. So this is a trial that's unique to City of Hope and Florida and New York. There's a couple places that do this. It's called pressurized intraperitoneal aerosol chemotherapy, or PIPEC. So the chemotherapy is actually given in an aerosolized form. Like the bottle Lysol, if you spray it, the old cans, it's a gas is kind of release. This is done now directly in the abdominal cavity with chemotherapy, and it's experimental. It's only done in a handful of locations in the U.S., and we're one of them, but it can be a game changer. There are some patients who have really good responses to PIPEC. Dr. Dellinger, who's my colleague here at City of Hope, is one of the national PIs and a world leader in this. And so I would encourage you, if it's something where you're interested, to seek out one of these institutions. Again, there's really just 2 or 3 in the country. But if you have disease that's really localized to the abdominal cavity, and you're not a candidate for surgical excision, this may be a way to treat some of those lesions with an aerosolized form of chemotherapy. And it's really very open as far as it doesn't have prior restrictions with regards to the number of prior lines of chemotherapy as well. So that's going to be a more unique trial. It's more of a niche trial, but something to be aware of because the technology is there. PIPAC, PIPAC is the acronym. Next slide, please. This is a phase 1b trial, and this is a CAR T therapy. So CAR T represents probably the most new version of how we treat ovarian cancer, and it really represents the hope for immunotherapy. Immunotherapy treatments haven't quite panned out as well as we had hoped in ovarian cancer, but CAR T cell therapy or T cell related therapies are the next phase of how we're going to do this. And we all are extremely positive that this represents a better opportunity to use your immune system to attack cancer. So this trial is targeting TAG72, which is an antigen on CAR T cells. T cells are basically the cells that attack in your immune system. When you're sick, the T cells are the warriors that go out and kill the foreign body, the bacteria, or the virus, or in this case, the cancer. And so City of Hope is a leader in leukemia and lymphoma treatments, but that means they're world experts in how to use CAR T, because CAR T has been used in those disease processes for years. And so we have a homegrown CAR T program with Dr. Lorna Rodriguez for patients with platinum-resistant ovarian cancer. There are other trials open in a handful of other states, and that's why I mentioned this, because it's not the only CAR T cell therapy trial open. It's one of them, but look up clinicaltrials.gov, type in CAR T, and look up ovarian cancer, and you'll find what's available for you. But it is a specialized trial that requires comprehensive care with hematologists and gynecologic oncologists and medical oncologists. You have to express certain receptors on the tumor and in your own immune system, and that's what's on the slide. But just know the future is here, and these trials are very exciting. Next slide, please. This is another example of T cell therapy. This is not CAR T therapy. Basically, these T cells are being used to generate a way to, they're trained to attack the tumor specific to your body, but you have to have certain expressions of these of receptors, and that's what's on this slide. The ADP-A2M4CD8 cell. You have to have a certain human leukocyte antigen expression, and you have to have a certain MAGE A4 expression, and your doctor can test for these. This is called Surpass-3. This is a trial that's really one of the first national trials or international trials looking at T cell therapy for ovarian cancer. It's open, it's GOG 3084. It's open in Arizona, California, Georgia, Michigan, New Jersey, South Dakota, Texas, Washington, Ohio, Oklahoma, and Toronto. And there are other versions of these trials out there. So T cell therapy is here. It's experimental. This is not something you're going to get as a standard of care. I would say the time to use this is when you're doing a little bit better. This is not that you don't want to wait and use this when you're in a tough spot with chemotherapy after 8 prior lines. You want to try to use this earlier because these drugs can make you pretty sick. But again, if you respond, they could be game changers for you. Next slide, please. We're almost done with this, and then we'll get to questions. Okay. So really, I'm going to move through a little bit more quickly through a couple of these studies. This is a study looking again at another folate receptor target. It's called IMGN151. It's looking at platinum-resistant ovarian cancer. It's targeting high-grade serous patients, and it's open in California. It's open in Florida, Michigan, New York, and Buffalo at Roswell Park, Oklahoma, Tennessee, Texas. So really another opportunity for you to use folate receptor and be treated on this. And you could have already been on a prior folate receptor. So a lot of these new trials that are available for folate receptor allow for prior folate receptor drug exposure. So even if you've already received mirvetuximab, you still may qualify for a trial like this. If it's not this one, it may be another one. Next slide, please. This is an example of something called a bispecific antibody. So this is a phase 1/2. This is Regeneron. This is a drug that has 2 linkers on it that target 2 receptors in your immune system. And it's really an exciting opportunity to activate and target T cells in your body. It's open in California, Florida, Illinois, Massachusetts, Michigan, New York, Ohio, and Washington. It also is something that does require at least 1 prior line of platinum chemotherapy. But otherwise, you can have had prior lines of treatment, and it's pretty open to the different histologies. If you have carcinosarcoma, you wouldn't qualify, but clear cell, endometrioid, all these others, you likely would qualify. So this is a good trial for someone who's looking for a trial that unfortunately may not qualify for others. Next slide, please. This is a drug that is another antibody drug conjugate, and it's targeting BH-H4. The name of the drug is puxitutag semrotecan. I know that's a mouthful for me too, but it's a drug that's targeting this antibody on cells. It's an antibody drug conjugate. You have to have measurable disease, meaning you have to have recurrent cancer that's not responding to other treatments. And it's open in California, Florida, Louisiana, Maryland, Massachusetts, Missouri, New Mexico, New York, North Carolina, Pennsylvania, and Texas. And so this is again another antibody drug conjugate that's moving up the chain here as far as it may be the next folate receptor alpha. We're not quite sure. We're looking for that. Next slide, please. I want to switch and talk about low-grade serous ovarian cancer for a moment. I know I have not touched upon it a lot, but it is a drug that it is a tumor that we do have trials for. The biggest trial right now is GOG 3097, which is the RAMP 301 study. I think there was a talk through Share about in June or July that talked about low-grade serous ovarian cancer. You can certainly reference that. But this is involving 2 drugs, avotumetinib and defactinib, and they're being used in the setting of recurrent low-grade serous ovarian cancer, where you may get those drugs or being randomized to a standard of care chemotherapy. And the nice thing about this for low-grade serous is it's open in many states: Arizona, California, Connecticut, Florida, Illinois, Louisiana, Michigan, Minnesota, New York, North Carolina, Missouri, Pennsylvania, Oregon, Ohio. And so if you go to clinicaltrials.gov and you type in ovarian low grade or ovarian cancer, or if you want to just type in ramp and ovarian cancer, this will pop up and you'll be able to find this trial if it's open near where you live. Okay, next slide, please. And so just kind of some summary slides here to finish out the presentation. So things to keep in mind: seek out an organization such as Share. Talk to people with Share. They're here to help, and it's a great way to get started in the setting of recurrent disease to maybe get your bearings where you need to go next. Stay connected with your family and friends. I know it's really hard because we get sad, we get depressed, we're dealing with cancer, but we know patients do better when you have a support group. We know that you do better when you have friends or family. Don't be worried about sharing this with them. They want to be there for you. They want to share this with you. It's not a burden to them. So to reach out to them, we want you to be there. Your doctors we want to be there with you. Share with us how you're feeling too, because we want to help in any way we can. Cancer centers offer more than just drugs. We don't just push trials. We don't just push chemo or Taxol, which is a plant. We also offer symptom management, nutritionists, mental health, integrative medicine. And if your cancer center doesn't offer that, find one that does. Comprehensive cancer centers usually have to offer that. NCCN cancer centers. Seek a second opinion. It's okay. Get the path reviewed. Get your imaging reviewed. Get it. Talk about clinical trials. This is your life. It's okay to advocate for yourself. If insurance is a barrier, there are ways to overcome that depending on the institution. That's a little harder, but with telemedicine and travel, there are ways to do second opinions that you may not have thought possible. Next slide, please. Keep physically active. Take control of your diet and exercise. Those are things you do have control over. Stay at a healthy weight. Those are things we have a moderate amount of control over. I spend a lot of my day talking about drugs and diet and fads. Everything in moderation. Fruits and vegetables, whole grains. That's really the approach here. I recommend a Mediterranean diet. There's not one fad diet that's really better than anything else out there right now. There's not a product that everybody should be taking as a supplement, but everything in moderation, avoiding sugary drinks, highly processed foods. That being said, completely removing sugar from your diet is not the be all end all. If you're out with your family and you want to have something and splurge, it's okay to do that if it's enjoyment. Once in a while is okay. Just everything in moderation. As much as you can, don't live CT scan to CT scan or CA125 to CA125. Every day is a gift, and I know that for myself. And you have to make the most of it. But just know that the drugs are the drugs, the trials are the trials. The doctors are going to do their best to follow you, but you can't just wait for that next CA125 because life has to happen in between. You have to enjoy time with your family between every 3 month scans or every 6 month scans. So don't wait for those results. Make the most of it because I think we all need to do that. And then if you can avoid alcohol, the idea one red glass of wine a day is actually not accurate. We've moved away from that. We don't think red wine actually helps your heart. So just know that it's okay to a little bit, but I wouldn't do more. I would try to stay away from alcohol routinely if you can. If you're out with your friends and family, by all means, go for it, but just in moderation. Next slide, please. Meet with your medical team, advocate for yourself, ask questions. It's okay to get a second opinion. Ask about the tumor board. Know there's more than one option. Stay connected to friends and reach out to organizations such as Share. Next slide, please. So 3 key take homes for you. Ask what the tumor testing has been done already. If you have recurrent ovarian cancer, you should have folate receptor testing. You should have HER2 testing. Your tumor should be tested for estrogen and progesterone receptors. And there are more targets out there. But at the very least, know what's been done. Know if the term is HR deficient, HRD positive or negative. And then discuss the role of additional imaging, surgery, and whether you need a new biopsy. Everybody with recurrent ovarian cancer should have this discussion with their doctor or doctors. And then clinical trials are opening and changing all the time. Your medical provider should send you to a location that has trials. Even if they don't, they should be able to offer that to you because in the day and age of recurrent ovarian cancer, we have a lot of exciting new treatments that you will have access to through a trial that you will not otherwise see. And if they can't offer it to you in that setting, that's okay. That's not the expectation of every cancer center or every group in the country, but you should be able to hear from someone who has trials to offer you. Next slide, please. I mentioned City of Hope. I love working at City of Hope. We are now City of Hope Duarte in California, Orange County, where I am. There's also City of Hope Atlanta, Phoenix, and Chicago. So if you live in one of these states, you can certainly seek information from City of Hope. But I know there's lots of great places out there, and I'm happy to give you any input I can as far as where you might be able to go depending on where you live. Again, clinicaltrials.gov is the key, though, to start with looking for trials. Next slide, please. So this is my email address. This is my Twitter handle or X handle now, and Instagram. I try to be active on there if possible with things that are coming up with ovarian cancer, or at least maybe new things that are being said in the literature. And so with that, I'm open for questions.
Thank you, Dr. Cohen. That was an excellent presentation. You covered a ton of ground. Really appreciate it. So now let's start the Q&A. There were a lot of pre-submitted questions, and you can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as we can in the time remaining. All right, so let's get started. So I know that you touched on, I believe there was at least one trial that was open for those with clear cell tumors, but I'm wondering if there's any other clinical trials you can speak to that are recruiting for clear cell. And then also as a sort of follow up to that, we received a question about sort of how can we sort of get the medical community to include clear cell or do more trials on clear cell ovarian cancer.
Yeah, and thank you for that question. I think we actually have trials that are in the pipeline and upcoming. There are trials looking at combination with immunotherapy. I think one of the things about clear cell is that it's not just within ovarian cancer. There's clear cell cancer of the kidney, which is probably more common actually. And so when you're looking for a trial, even just typing in clear cell into clinicaltrials.gov and maybe not limiting it to ovarian cancer, because many of these trials are agnostic of tumor origin. And it just may be the fact that someone has a clear cell tumor. You may find a trial locally that's not specific to ovarian cancer, but it may offer you the opportunity to enroll on that trial. We do know that clear cell tumors respond better to immunotherapy. And I know that I mentioned that we are looking for CAR T and T cell therapy, but honestly, clear cells are some of the few tumors that do respond really pretty well to pembrolizumab, which is already approved, or nivolumab and pembrolizumab. So there are some trials looking at response rates to nivolumab and pembrolizumab together, or other combinations of immunotherapy in specifically clear cell populations. So
Mhm.
there are trials out there. Immunotherapy can be an option for you. I have patients who have clear cell tumors where maybe they weren't offered immunotherapy before, and they may not have the molecular signature, but we've put them on immunotherapy and they've responded. And we're still trying to figure out why that's the case. So if you have clear cell and you're listening, talk to your doctor about immunotherapy. Ask them about trials that may not be specific to ovarian cancer, but include clear cell tumors. But they are out there.
Mhm. Great, thank you for that. And then we're also getting a question again, more rare tumor types, but why is it more challenging to find trials for low grade serous or mucinous, or is it?
It is more challenging, and if you think about trials, really, when trials are designed, and this is the challenge, they're designed with the intent to hopefully show benefit. And when you're developing a drug, the way to show benefit is trying to focus on perhaps one specific tumor type to make sure it's consistent, and make sure that you have a response that makes that's real. When we go to the FDA for approvals, the FDA is the governing body for whether drugs can be given to a human being in the U.S. or not, or at least whether the insurance companies will pay for them if they're FDA approved. They want to see the data. They want to see what is the likelihood of response in patient populations. And unfortunately, mucinous tumors are rare and low-grade serous are rare. They tend to act differently than standard high-grade serous ovarian cancer. So when you're designing a drug for ovarian cancer, most pharma companies will design it and focus on high-grade serous because it's the more common type. It's the more likely type that they're going to get patients to enroll. And that's why that's the unfortunate reason. That being said, we as doctors are committed to treating patients with mucinous cancer and low-grade serous, and we have trials open, sometimes based on molecular signatures. Again, the trial may not say by name low-grade serous, it may not say by name mucinous, but you may have a mutation. Now, I will tell you, for mucinous tumors, you should get HER2 testing, because if you're many mucinous tumors, not more than half, but a number are HER2 positive. And if you're HER2 positive, guess what? Trastuzumab deruxtecan, that ADC I mentioned, that's a game changer for you. So if you're out there and you're listening and if you have a mucinous tumor, make sure you've been HER2 tested, because there's a good chance you may respond if you're positive for it. For low-grade serous, there are actually more trials upcoming. We actually have an upfront trial looking at an aromatase inhibitor alone versus chemotherapy for patients with low-grade serous ovarian cancer. And there are more trials. I presented RAMP because that's the biggest one and most available right now, but they are out there. So there are more trials that are coming out for low-grade serous. Again, talk to your doctor, go to an NCCN cancer center, go to clinicaltrials.gov, but they're coming out, and get that get that sequencing of your tumor, because that's going to open up the door for other treatments that may not just be specific to low-grade serous.
Mhm. Great. And then we're getting a question about what is the benefit of pressurizing chemo? Does it act differently?
Yeah, so when it's aerosolized in the abdominal cavity, it covers the entire surface area of the abdomen and penetrates the tissue. So it basically is covering or bathing the abdominal surface in chemotherapy, and then it gets absorbed through the lining or the saran wrap called the peritoneum. So it's a nice way to deliver chemotherapy droplets throughout the abdomen. Where if you're doing chemotherapy in the IV, it will eventually reach there, but you're relying on blood vessels reaching those areas through your veins versus direct delivery. It's a trial. It may not be the be all end all, but actually, if you have low grade serous ovarian cancer, there's been some really good responses with PIPEC in our study. So that's an example. If you have a disease confined to the abdomen and you have low grade serous ovarian cancer, you may want to seek out a study on PIPEC. You can enroll in that trial, PIPAC, and we've had some really good responses with Dr. Dellinger's work.
Great. And then we're also getting a question about age limits when it comes to clinical trials. Are there cases where patients are too old to participate?
It's no, it's be really rare. I mean, there are some, but honestly, the nice thing that we've seen movement in trials now is being more inclusive. The younger ages is a harder stop. 18 or older is really kind of the cutoff, unless you're a pediatric designated trial, which has its own regulatory body. But really, outside of that, most patients can enroll. It's going to be more performance status. Are you able to do things, activities of daily living? Can you button your clothes? Can you feed yourself? Can you eat and drink and supply yourself with nourishment? That's going to be more the rate limiting step than to someone who's 80. I would still talk to someone who's 80 about a clinical trial. I enroll patients who are older than that in trials. So I don't think age is the limit. It's going to be more the term is frailty and performance status.
Mhm. Great. And this is just a more general question about sort of the role of clinical trials. Like, is it the doctor's job to bring clinical trials to the patient, or should patients be going to their doctor asking about clinical trials?
Advocate for yourself. I mean, it depends on the provider. I would say I love going to work and talking about trials with patients. Many of us do, but not all providers do that. That may not be their strength. So advocate for yourself. Thank you for listening to this. If you're a family member, advocate for your family member. Everybody should have the opportunity to discuss clinical trials because there's some really exciting things, but it may not be the provider. So unfortunately, it may be you. And so it was on my slide. I'll say it again. Advocate, advocate, advocate.
Great. That's so important. And then in instances where a patient may be on a treatment but having eh, side effects, is that a good time to think about clinical trials for other treatments?
I think it depends on the side effects. It depends. Usually, we try to keep you on a drug if you're responding. And I mentioned this as a chronic condition like HIV. If the drug is working, we can try to dose reduce it. We can try other treatments for the side effects like neuropathy, different medications. So I would really try to keep you on that drug as long as the cancer is responding. But sometimes you can. Sometimes you have to change direction. And if you're having a lot of toxicity, then yes, that's a good time to think about a trial. I think trials should be moved up. We should think about them earlier in the setting of recurrent cancer versus later. They're not a last ditch effort. They should be moved up because you could get a really great drug that could change the course of how you're being treated. But unfortunately, I feel like most patients don't hear about trials till it's much later in their disease course. But toxicity alone would not be a reason to move away from a drug.
Mhm. And then this person is asking about, so the FDA cleared an investigational new drug application for ZW191, which is another ADC for folate receptor alpha in ovarian cancer and other tumors. Is that an option or now or only in clinical trials?
The only FDA approved drug right now that's mirvetuximab that's being approved and paid for by insurance companies. That being said, if you have a drug, you can always go to you can have your provider go to the company and ask for use perhaps outside of a clinical trial. That's where you have to have your provider advocate for you. But I would say if it's on a trial and you're going to qualify, that's the best place to get it on a clinical trial because that's you're going to get that drug as that part of the trial sponsor paying for it. But if it's not on the NCCN guidelines, the list I gave you, and it's not FDA approved, the insurance company is definitely going to say no. And that's where, if you really believe in it and your provider believes in it, they have to get on the phone with the pharma company and start making phone calls and see if there's a way they can get it for you outside of the standard process.
Great. And that's all the time we have for questions. So thank you so much, Dr. Cohen, for this extremely informative program. And thanks to everyone participated today and asked all of these great questions. Uh, Please check out Share's upcoming educational programs and support groups. And follow us on social media as well. So, as you can see, here's some of our upcoming programs. And that concludes the webinar. So, thank you again, Dr. Cohen. We really appreciate you participating in this tonight.
My honor. Thank you all, and wishing you all the best. Thanks so much.